cover a few things with all our cardiothoracic patients. Most of this you guys already know, but want to do a little refresher on what we expect with our cardiothoracic patients, what the general course is, and when to call if you have any questions or need help. I'm mainly going to focus on heart patients, because that's the majority of our patients, but a lot of these same concepts apply to thoracic patients as well, just with generally a little bit of slightly different in terms of chest tube management and things like that. Generally, when all of our hearts come out of the ICU to you guys, they've just gotten rid of their central line, swan, they've potentially been hemodynamically unstable for the past couple days, or maybe they've been rock solid. So a few things to just really keep an eye on when you first get your patient is just assessing them, their vital signs, are they stable, have they not been? A lot of that the ICU nurse can give you in their history. Another thing is just making sure all their chest tube connections are correctly together, making sure their incision looks clean. A lot of the times the main incision, the bandage can come off and you can at least check it and put it back on. Most of the time their chest tubes should be to water seal by the time you get them. A fair number of our patients will still need temporary pacing at the time that they're transferred over to you. Dr. Logson wanted to go into more detail about temporary pacing, how the mechanisms work, but in general, you have to make sure the V wires are correctly connected to the V input, the A's are correctly connected to the A input, and just pay attention to how much the interference is turned up on the A and V wires, and then also on their EKG, make sure they have a normal P wave, they're not in a junctional rhythm, and the pacing isn't interfering with their RRT waves. The chest tubes in general, you want to check to make sure there's not an air leak. If there is, we generally always know about it, but it's always a nice thing to know when we're rounding if you see one or I saw one at one point. Another thing to keep in mind is, are they leaking around the chest tubes, either fluid or air? Sometimes we have the chest tubes clamped for some period of time, and just something to keep in mind when the chest tubes are clamped, if the patient all of a sudden gets short of breath, their sats go down, that would be a concern to call us to make sure that their lung hasn't collapsed while the chest is clamped, or the chest tube is clamped. And then in general, we really want our patients up and moving. That's something that helps get our patients home earlier, prevent pneumonias, prevent blood clots. We like them walking 3 times a day. A lot of the time the patients won't ask to walk and need a lot of pushing and encouragement from you guys to make sure they're up and moving, out of the bed to the chair for meals. Dr. Cohen wants to make sure all of the patients have their leg squeezers on at all times when they're not walking. That prevents blood clots and therefore PEs, so that's super important. Another thing is that we are actually generally okay with patients showering once their chest tubes and their wires are out. I know generally that makes patients just feel better to have showered. That's probably something we maybe don't do enough towards the end of their surgical stay. But yeah, ambulation is super important, coughing and taking deep breaths, using their incentive spirometer every hour. A lot of patients really just need to be pushed. And then in addition, staying on their normal, or not normal, but staying on a bowel regimen. All patients will have Colace twice a day, and then all patients should have a handful of as-needed laxatives. That generally it feels like we're waiting until day 2 or day 3 to start giving those, but once they come to you, I would at least offer it once a day to the patient to make sure that you're staying kind of ahead of that situation, so it's not we're trying to discharge them and then waiting for a bowel movement. Another thing is just daily x-rays. They're all expected to get daily x-rays with the exception of once their tubes come out. They generally don't need x-rays anymore. Mostly they'll be getting labs in the morning. You don't necessarily need to call for abnormal labs unless they're very abnormal or whatever your protocol is, but we're always looking at the labs in the morning. And then I know Dan Logston wanted to do a separate video informationally about things that affect the fellows more commonly, what they get called about, what they appreciate knowing, what they don't care to know. Just knowing that we're always in the morning checking on all the labs and x-rays and all that stuff. In general, I will commonly get patients ready to go home for the weekend on Fridays. So if you see discharge orders on Fridays and you're confused because that patient's nowhere near ready to go home, that probably just means I was setting it up for Sunday or whenever they might be able to go home over the weekend, especially if it's a holiday weekend.
Hi, I'm Dan Logston. I'm one of the heart surgery fellows here at Huntington Hospital. So today I think the purpose of this is just to talk about, I know Melissa spoke, she's our physician associate, that talked a lot about some of the other like overview of these patients, and I'll probably repeat some of what she said, but also just want to kind of go over expectations of these patients. Any center that does as many hearts that Huntington does, and the patients that we get here that can oftentimes be sick, it's very important. We rely heavily on our nurses, and so that's why we're taking the time today to chat about this. So the first thing is expectations. You have to remember that heart surgery patients need to be up and they need to be moving. They're not meant to be in bed. They're always meant to be up in a chair, always meant to be walking. They recover so much faster the quicker we can get them there. On the ICU side, our goal is to really extubate them within the first 4 hours of being having their heart stopped. Most people have had their heart stopped as long as we stop it for. Like today's case, we stopped it for 85 minutes, all of us would be dead. Well, they're not, but it's very important we get them back up and moving quickly, so we get the reading tube out quickly on our end of the ICU, and then the following day they typically are coming to you on post-op day 1. So our expectations is that one, at shift change, it's very important to know what procedure your patient had, specifically heart and lung surgery patients. It's very critical to what the problems that may arise are. So it's very, very important that you guys know exactly what happened to those patients. If you don't, ask questions to us and then pass it down to the nurses at shift change. We're happy to teach, we're happy to explain, all of us are very approachable. The next thing that we expect is just physical exams and a med review at kind of turnover. These patients, in our opinion, take top priority just because of the nature of what they've had done to them. If it goes well, they're going home in 4 days. If it doesn't go well, they may be spending weeks here or even worse. So, these patients for the first few days can be pretty tenuous and require a lot of attention. And so, really, when you get these patients, we expect that you guys are part of the care team, a big portion of it. We look to you guys and kind of your training to really look over the patients, examine them, and we'll kind of talk through what to expect to see in them, and then things that you guys can communicate to us. The other thing is med review. We'll talk through some of the common meds that they're on. Some of them will be on some other meds that you're not sure what they are or why we started them. We'll kind of explain them. But there is kind of a routine and a rhythm and role to heart and lung surgery. So some things that you'll see on all of our patients when they come to the DOU, you'll see chest tubes. They all have tubes that are just meant to drain extra fluid around the heart and the lungs until they put out somewhere less than about 150 milliliters per day. And so we'll always ask you to record those in the chart because we base what you record on that, whether or not the tube can come out. And if we take the tube out too early, they can develop effusions, and that's one of the complications that can happen, and then they have to go get another tube put in and undergo anesthesia. And so it's very important that you document that. It's also important to document the pacing wires. Every patient has pacing wires that we suture to their heart after surgery. Those will come out at some point in the DOU. Typically, we pull those wires out and they require 2 hours of bed rest, just so you can monitor them and their vitals every 15 minutes, because we are removing something that's stitched to the heart. Often, if the patient's on anticoagulation, outside of subcutaneous heparin, so if they're on Coumadin or Eliquis or Plavix, we'll typically have to cut those wires and leave them in. And we'll discuss that with you. But you should know what the pacing wires are, where the pacing box is, how to connect them, how to disconnect them, and what mode they're in on every one of those patients, and that should be signed out. The other things that need to be checked, one, the Foley catheter should come out on post-operative day 1 on probably 80% of our patients. We use it to, one, monitor fluid output, specifically in the first 24 hours, to get an idea of how the kidney function is, but usually by the time they come to you at the DOU, the Foley will be out. And so therefore, it's going to be very important that you monitor their urine output and be like accurate eyes and O's on these patients, because we are, after heart surgery, there's a lot of large fluid shifts, and so you'll see edema in their their legs. That'll go away as we start to diurese them, and that's one of the things that our job is to make sure their fluid status is what we call euvolemic. So they're not hypervolemic, they're not hypovolemic, euvolemic. We want all of our patients in euvolemia. That's where heart patients function the best. And so we depend on accurate eyes and nose to make decisions on how we're going to continue to diurese these patients. And then the other thing that they'll have had is usually a central line. We typically use the right internal jugular as our first choice, sometimes the left, and sometimes the subclavians. Sometimes these line sites, we take them out in the ICU, they'll come over with the dressing. Sometimes we expect those dressings to be taken off by like day 2 here, and the site inspected and checked out. Sometimes, like today, one of the patients had some bleeding from there, because sometimes they're on blood thinners, and we place them with a dressing there. So that's something that you always want to check, is where they had a central line site. And every heart surgery patient will have had a central line site. The next thing that we do is we do something called expedited recovery after anesthesia. It's called ERAS protocol, and that dictates our pain management that we do. So all of our patients preoperatively go on to Tylenol, gabapentin, and Celebrex. Postoperatively, we typically put them on Tylenol, IV, gabapentin, 300 milligrams 3 times a day. And then from there, we'll use tramadol and sometimes oxycodone, and then break through with morphine. That's just our standard protocol in all the patients. And so that's kind of the way we like to do it. We try to get away from the narcotics because it causes issues with bowel movements, as you know. And so that's the other thing about getting these patients up and mobilizing. So part of the ERAS protocol is getting them up and mobilized. So very little time in the bed, most of the time in the chair. And then usually by day 2, day 3, as the tubes are starting, chest tubes are starting to come out, they should be mobilizing a lot. They should be walking 3-4 times a day around the unit. I know it takes a lot of time to do it, but we appreciate it. And those patients typically go home a day or 2 sooner if the nurses are able to get them up and get them walking. So the common procedures that we will perform here that you'll see coronary artery bypass grafting. And there's a couple things we do. We take an artery from the chest wall called the internal memory artery, and we always sew that to the left anterior descending artery on the heart. That's one of the whole reasons we do this surgery, is for that graft. It's very important. The patency rate, meaning how long it stays open, at like 15 or 20 years is about 95%. So that graft is very important to stay open. That's what's keeping them from having heart attacks and prolonging their life. So that's one of the best things we can do for patients with coronary disease. The second thing that we do, we take a vein from one of their legs, so the saphenous vein. So each of these patients that have what we call a cabbage for short, will have a small incision on their leg. They have an endoscopic saphenous vein harvest. Those veins is taken, and we use those to make new arteries for the heart. And so you want to make sure in those patients you're looking at their legs. And so it's going to be important to know how many grafts they had, what grafts do we do, and where those arteries are on the heart. There's 3 main arteries that we talk about: the right coronary, the left anterior descending, and the left circumflex artery. So those are the arteries that we'll be bypassing. There'll be different targets in that area that we'll bypass, and those are all in our simple operative report, and we're happy to discuss them on the patients, but it's very important that you look over those. Those patients, as with all of our patients, they're going to be on subcutaneous heparin, they're going to aspirin. I would say 95% of them go home on a beta blocker. That's a requirement. That's like a protocol thing that not only we do, but they do it nationally. So they should be on some form of a beta blocker. Reasons that they would not be on a beta blocker is because their heart rate is too slow. So anything less than 60, we would hold the beta blocker. We'd also hold it for hypotension. So anything less than a systolic pressure of 90, we'll hold the beta blocker on them. And some patients can't tolerate it, and that's about 5%. The other meds that they'll have, so they'll have the aspirin, the subcu heparin, the beta blocker. They will go home on a diuretic. All the patients, probably 90-95%, go home on a diuretic, and it's typically Lasix. So we usually start that as an IV form, and they'll come over here for a couple days with IV, and then we'll transition to a PO form. So you expect to see that they're getting Lasix, and remember, we need the accurate urine outputs there. And then the other things for cabbage patients to watch out for, sometimes we'll start them on Plavix. So it's very important to know if the patient's on Plavix, Coumadin, or another DOAC like Eliquis or Xarelto. The other patients that you'll see are valve patients. So they're patients that we've changed out one of their heart valves. It'll typically be an aortic valve, a mitral valve, it could be a tricuspid. Those are patients that we see often and do. And so those patients have similar med regimens to the coronary patients. They'll be on an aspirin, they'll be on subcu heparin, they'll be on a beta blocker, they'll be on a diuretic. And then at this hospital, we use Coumadin for even the bioprosthetic valves, so the tissue valves, or we always use Coumadin. And for the prosthetic valves, which we call mechanical valves typically, those patients are required to be on either a heparin drip or have to be completely anticoagulated, an INR above 2 or 2.5. And then things that you're going to see over here in the DOU, you're going to see different forms of rhythms. We love sinus rhythm, we don't always get it. So you're going to see a junctional rhythm, meaning the atrium and the ventricle are contracting at the same time. And you're also going to see atrial fibrillation. And we expect you guys to know how to treat atrial fibrillation. We have a standard protocol we use here. We typically use a bolus of amiodarone. It's typically 150 milligrams of amiodarone that we give, and then we start them on a drip of 1 milligram per minute that they'll get, and that allows them to load the amiodarone. And so that's a standard protocol. And so oftentimes you'll see that they go into atrial fibrillation, and when that happens, their heart rate is going to pick up. It's going to go from something in the 70s or 80s up to 130s, 140s, 150s, something like that. And typically we will get a phone call. You can either call us or the cardiologist, but we expect you to know the treatment plan for that. It's going to be, amiodarone. If there's something different, we'll let you know. Other rhythms you may see VTAC or VFib, and so it's going to be very important that you understand how to do your ACLS. You will have patients here that are heart patients that will arrest on the floor. It's going to happen. It always does. It's rare, but when it does happen, you have to have nurses that know how to take care of it. So we look for you guys to do that because we're typically in the operating room and not around. And so it's very important for the heart patients that are being taken care of each shift. I like when the nurses know who's got heart patients. It's very important to remember what room numbers they're in, because those patients that have an arrest are very salvageable. They very much can be saved. This is typically something that can be reversed because these patients have walked into the hospital, they've undergone heart surgery, they've recovered, for the most part, and they've had some arrhythmia, and it can be due to a large myriad of reasons that we can discuss at another time. But it's very important to know to recognize VTAC, VFib, and that brings me to the next point about pacemakers. So yes, the pacemaker, I know you'll have a course on that, and so you'll have a couple settings that we use. We either use DDD, which is dual chamber pacing, pacing the atrium and the ventricle, and then you're also going to have VVI, which is our backup setting. The safe setting for any pacemaker is always a ventricular contraction. If you just have an atrial setting on your pacemaker, that is not a fail-safe mode. So that will not save the patient's life if it just contracts the atrium, because if there's no conduction from the atrium to the ventricle, that patient will not live. Just contracting the atrium will not allow the patient to survive. So it's important to know how to do that. And complications that we see commonly after heart surgery: number one, bleeding. We typically won't transfer the patients over here if they're bleeding in the ICU, but occasionally here you will have patients that develop large amount of bleeding and output from the chest tube. So if the output is sanguinous, meaning it's bloody looking, and it's over 200 cc's in an hour, we want to be called about that. Call us directly and we'll come over and see the patient. Typically, if patients have been laying flat and they get up in the morning, they may drain some serosanguinous fluid. But if it's sanguinous and the patient is becoming hypotensive, give us a call. It will happen if you are a nurse taking care of heart patients, guaranteed. And so just put that in the back of your mind. Number two, they'll have rhythm issues. They'll have atrial fibrillation. About 25% of patients have atrial fibrillation. We discussed that already. Three, you'll have patients that will develop wound infections. So it's not uncommon. Probably 2%, 3% of the patients will develop a wound complication. And these patients are diabetics. Almost all of them, 100% almost, are diabetics. And so the blood sugar control is going to be very important for them. And this wound is going to be very important to watch and to heal. So we expect you guys to be examining this. When you see the patient, there will typically be a dressing over that's like a Mepilex dressing that can be removed on post-op day 2. Underneath, you'll see some surgical glue and some surgical tape that's meant to stay on there. When the patients go home, that tape's typically removed off when they come back to clinic, but when they go home, we expect them to scrub and keep that clean. And so sometimes you may see a little leaking coming out of this, a little clear fluid coming from the incision. We just like when dry dressings are put on that to keep it as dry as possible. You'll have also a couple of chest tube sites that have sutures in them. After the tubes are removed, we'll typically tie those down, but there may be some seeping from that you'll see. It's typically not infected, but we just have to put a dry dressing on it. Respiratory complications. So these patients have lost about 30% of their respiratory function when their breastbone is divided. This leads to very high incidence of pneumonias in these patients, which is why it's very important to mobilize them. Pneumonias being another complication. So these patients have had their sternum divided, typically. They lose about 30% of their intrinsic respiratory function until that chest stabilizes, and it takes about 8 weeks for that bone to heal. And so we expect them to not have anything more than 5 pounds of weight in either arm. We don't let them drive for 30 days. That's our policy here at Huntington. And when they stand up, we expect them to use their legs and nothing that's going to stretch their breastbone here. That is a common complication that can happen is that somebody, especially a larger patient, can pull these apart. With talk about pneumonias and things too, when they lose that respiratory function, we like them to use their incentive spirometer 10 times every hour. And to be up, like we said, and to be mobilizing. That will prevent pneumonias until their lung function and their ability to breathe deeper has improved. They'll typically be coughing up a lot. A lot of these patients are smokers, and so expect them to be producing a lot of phlegm. So I think I'll kind of summarize it all. We really, to take care of a heart patient is a very special privilege. Not every nurse gets to take care of heart patients. They do have some extra special requirements. They require a little more diligence, a little more dedication to look into everything. We really look to our nurses to be a part of the care team, a very important part. Like we'll come to you right away and ask how they're doing and what's going on, even before we check the chart. We want to know how they look, what their labs look like, what their x-ray looks like. If you've looked at that, it's very important to go through all of those if you're taking care of a heart patient, because every little bit matters for these patients in order to get them home to their family. And so I would just encourage you to be, one, to enjoy taking care of the heart patients and really learn a lot about the physiology and what we do in the operating room. It'll make a lot more sense when it comes to caring for these patients. I also think it's very rewarding when you get to see them post-operatively, which I know you don't get to see them in clinic, but you'll see patients that have had their heart stopped, and 2 weeks later they'll be back in and they'll feel like $1,000,000. And that's why I went into the field, because the outcomes can be so great for these patients, but we really rely on the nurses and what you see and observe, because you're with them every day while we're in the operating room operating on other patients. So you're with them more than we are, and so your word matters. We take it very seriously what you guys say. We take your recommendations seriously. So hold on to that and just know when your words have power. So if you suggest something to us, oftentimes we'll adopt that. If we have an issue with it, we may challenge it and ask you a few questions about it. But oftentimes we'll listen when you call us or when you ask us to come by and tell us what's going on. This patient needs to go to rehab. This patient's not breathing well. We need to adjust their breathing treatments, or I think they're wet. We'll give them more Lasix, or hey, their heart rate's fast. We'll go up on their beta blockers, and we'll make those changes. And I think you'll find you'll find it very rewarding when you start to see that those recommendations you make are having a big effect on the patient. So if you see us in the hospital, just stop by, say hi. I'm actually graduating here shortly, so I may not be here, but there are other fellows. There's always more fellows to be found here. So thank you guys. We really do appreciate you here. We get to know you very well, that we have the current nurses that are here. So thanks again.